Hi, my name's Dr. Alif Musaji. You know me as the Smiling Dentist, and today we're going to talk about population versus personalized medicine. Population-based medicine is really important, but I don't believe it's the be-all and end-all of things. When we talk about population-based medicine, we're talking about a little bit about epidemiology. We're understanding what happens to populations in terms of health and disease. Now, it is important, especially for us as dentists, to understand trends. We want to know how often are we expecting to see disease? Because if we don't see disease in roughly the same kind of proportions as the rest of the population, it might be that we have an anomaly, or maybe it means that we need to calibrate what we believe health and disease is slightly differently. The other thing we need to understand, of course, is treatment and how well it works. And over a population, that's what helps to inform us with respect to longevity of restorations and modes of failure, because that really helps us to coach our patients and help them to understand what they might be getting themselves into if they pick a certain treatment option over another. But I want to share with you an experience I had when I went to see the GP. Now, thank God, my health is generally quite good, but I noticed that there were times where I was starting to breathe with my mouth open, especially at night time, and I worried that I had developed a nasal obstruction. So I went to see the doctor about it, and I felt that it was, if anything, a physical obstruction. I explained everything really nicely to the doctor, explained to them that I was, quote unquote, a medical professional as well. I know often they laugh at us because we're dentists, but anyway, that's a different story. But I tried to explain to him that with some, I suppose, not serendipitous but or contrary kind of opinion, I felt that there was something there that was going on. So I pressed him and he said, look, take this decongestant and go away, basically, in a nice way, and we'll try that for some weeks, and if there is still a problem afterwards, then come back again. So I asked him and I said to him, so what do you think the diagnosis is? And he said, I don't know, but this is the right thing for you. And I explained to him that surely as a medical professional, what we should be doing is taking a history, examining, doing any special investigations that we think is right, arriving at what we think is the correct diagnosis, and then treating appropriately. And you could see he kind of calmed himself down a little bit and his physiology changed a bit, and he said, yes, I guess you're right. And then I asked him, I do have private medical insurance. If I were to go privately, would this be any different? And to his credit, I suppose, he said, yes, well, it probably would be. I can arrange a referral for you to go and see ENT. So what I took from this interaction was that because the population-based medicine says that actually if we just throw decongestant at all of these people who present with a nasal obstruction, we will treat successfully maybe about 50% of the population, because that in the literature are the number of times that that presenting complaint leads to it being that problem. So the problem really is the 50% of patients for whom this treatment does not benefit. They are either having this treatment done inappropriately, or worse still, maybe something that's more time sensitive has now been missed and delayed for 6 months, and or 6 weeks rather, and after 6 weeks it will get no better or maybe worse, and it's only now that the appropriate investigation that they should have had done before is now going to manifest. And it really got me thinking a little bit about how if we try and treat a population, sometimes the person misses out. And it really got me reflecting on how I practice myself and how I try to interact with my own patients. I am very focused on personalized medicine or personalized dentistry for a patient. What I really want to do is to have a nice consultation with them where I can listen and listen and listen some more. Because not only is the problem important, but the patient's perception of that problem as well. Now, to give you an example, there have been times where patients have come in and perhaps they are aware that they have pain in a tooth, and then we take x-rays and we realize that they have an apical lesion perhaps associated with that tooth, but they maybe have another apical lesion associated with the other side. And so I will have a really nice conversation with them about both of them and how I will probably treat them differently initially. Where there is apical pathology and symptoms, the patient and I are aligned. We decide that we are going to either present the option of removal or we're going to try and treat the tooth, whether it be treatment, endodontic treatment, endodontic retreatment, and then whatever we need to do to provide protection to the tooth. But where we sometimes have asymptomatic lesions, and it's the first time I'm taking an X-ray of the patient, I will often ask the patient really if they're having any symptoms at all. And if they are, then I will push them to have treatment or respectfully request that they have treatment. If they don't, then sometimes I will often ask the patient if we can review the same area 6 months later to understand properly what's going on there. Now, the caveats are, when I do that I want them to tell me if there are any symptoms whatsoever, and they need to be coached that these chronic lesions can become acute at any point. And if they are worried or anxious about the prospect of that happening, then I would truly recommend they have treatment. The other thing I will explain to them is that if they are thinking that potentially they may want to have the tooth removed and have an implant placed, then of course we must treat that quickly. But I sometimes have patients with an asymptomatic 7, and maybe they've decided that even if they have the tooth pulled, they are not going to restore it. So for them, I say, as one grown up to another, if you are accepting of the risk that this could blow up into an abscess, then maybe it's acceptable for us to monitor this, because we don't know how long this quiescent apical lesion has been there. And maybe by doing root canal treatment, and perhaps if we got a complication that then did lead to pain, or to leading them to have the tooth removed sooner than they may have otherwise done so, you can understand why they may have umbrage, they may have a problem. This is where those stories of the patient who comes to the dentist with no problems and suddenly I had all of these issues after. This is where that kind of ill feeling can come from. So I find it so important to really listen to a patient, understand their desires, but also understand their attitude towards dentistry, because that helps me to understand how I'm going to treat them for that first 6 months. Then I will have more rapport, but I will also have the benefit of some longitudinal information that I can gain to even allow me to better make decisions about what treatment they should have and what we should leave. I find that that's a nice way, a pragmatic way to be treated, and my patients really appreciate that. And I think if I was a patient, I think I would fundamentally really appreciate that too. Thank you for joining me for this video, and I hope you enjoyed, and I hope you'll join me for more. Please don't forget to like, subscribe,